Good morning, everyone. Welcome to our webinar this morning on the COVID-19 vaccination monitoring in the WHO African region. We will give some few minutes to other participants to join, and then we can start. Please give us some 2-3 minutes to have other participants join, and then we can start. And welcome, everyone. Thank you. Okay, once again, good morning, good afternoon, everyone, wherever you may be. I welcome you once again to this webinar, the COVID-19 vaccination monitoring in the African region. Before we formally start, just some quick housekeeping rules. Yeah, so this virtual training adheres to the code of conduct to prevent harassment, including sexual harassment at WHO events. For questions and chats, take note of the icons at the bottom of the screen. For any questions regarding the topic and presentations, you should use the Q&A icon on the chat. For the live questions, it will be taken at the end of the presentation. In fact, we have a session for that, while the Q&A questions related to the topic and presentation should be directly reported on the Q&A chat. For the chat feature, we use it for IT or logistics. So you can see the icons at the bottom of the screen. This webinar has presentations for English, French, and Portuguese, and you can access that using the interpretation icon at the bottom of the screen as well. So once you click on the interpretation icon, you can choose the language that you would like to hear. A quick disclaimer that the interpretations of these proceedings is just to majorly facilitate communications. It doesn't really constitute any authentic or verbatim record of the proceedings. For live transcription, you will need to check for the icon show captions and click on it if you want to see the transcription on the screen. Otherwise, you click the hide captions. Note that this session is being recorded, and for you as a participant, we take your attendance as consent to be recorded. The materials, including the recordings, will be emailed to the participants in the days following the webinar. And then we would like to share a survey at the end of the session, and we highly encourage you to help us share your thoughts and suggestions. Your inputs will help us to be able to tailor future sessions to better meet your needs and expectations. And now to the agenda of the day. My name is Ajiri Atagwaza. I will be moderating this session. And we have this agenda as outlined below. The opening remarks, we have some quick 5 minutes for that from Professor Charles Wisoge, the VPD coordinator, after which we will have the overview of the COVID-19 vaccination in the region by Irina Doshi, and then the SAGE COVID-19 vaccine roadmap, the updated version, will be presented by Joachim Homberg from the SAGE Secretariat. And then for the writer recommendation, we have the writer chair herself, Professor Helen Rees, will be here. And for the revised global COVID-19 vaccination monitoring framework, for that session to be handled by Donald Brooks from the WHO HQ, while I will handle the session regarding the actions that is required for the Afro countries regarding reporting of the COVID-19 vaccination going forward, the COVID-19 vaccination data going forward. Then we'll have a quick overview of the EGRF platform for the COVID-19 vaccination reporting, discussion session, and closing remarks. So without further ado, we'll welcome Professor Charles Wisoge to give his opening remarks. Thank you.
Thank you so much, Ajiri, and good morning to everyone. So welcome to today's webinar on the revised COVID-19 vaccination monitoring framework. in the WHO African region. It is my privilege to guide you through this crucial session aimed at navigating the strategic shift in COVID-19 vaccination from an emergency response to its integration into routine health services. While COVID-19 no longer constitutes a public health emergency of international concern, it remains an important health issue. COVID-19 vaccination continues to help protect people against severe disease and death. Therefore, understanding and monitoring the coverage across the African region remains a priority. As we move towards more sustainable ways of managing COVID-19, including the inclusion of COVID-19 vaccination into primary health care, we must also adapt our reporting framework. The objective of this webinar is to provide you with a comprehensive update on the revised monitoring framework that takes effect this first quarter of 2024. We will delve into the implications of this transition and how it shapes our path going forward. Today's webinar speaks directly to expanded program on immunization, EPI managers, COVID-19 vaccination focal persons, and data focal persons across WHO African member states. Your role in adapting to and implementing this revised framework is very vital. The insights shared today will be instrumental in aligning national vaccination strategies with our view to this new long-term management approach for COVID-19 vaccination. As we enter into this new phase, your dedication to accurate and timely data reporting remains invaluable. These efforts are essential, not just for monitoring progress, but also ensuring that equitable protection of communities across the globe happens. I encourage you all to engage actively in today's sessions, ask questions, share insights, and let's collaboratively navigate these changes. Together, we can and we must continue to make strides in our mission to safeguard the global health. Thank you for your commitment. Thank you for your participation, and thank you for your ongoing efforts in this crucial endeavor. Let us make this transition a milestone in our journey towards a healthier and safer world. Thank you. And with this, I declare this seminar started. And over to you, Jerry.
Thank you very much, Professor Charles, for that insightful opening remarks. We'll move on to the next topic, which is the overview of current COVID-19 vaccination in the region. And this will be taken by our own Rina Doshi. You have 10 minutes for that presentation. Over to you, Rina.
Good morning, everybody. Hopefully you can hear me. And thanks so much for joining today. So a lot of you have seen this data over time over the last couple of years. So I'm just going to give a brief overview of where we stand today. So as we all know, COVID-19 vaccine rollout was the fastest delivery in history. You know, we had new vaccine technologies in just 1 year after the first case. 12 vaccines were approved by WHO in 3 years. 99% of member states introduced COVID vaccine in 1 year, and there were 13.6 billion doses that have been administered globally. 67% of our total population globally has completed the primary series, and we've prevented at least 14.4 million deaths. And also, most importantly now, we've increased country experience vaccinating adults. So here's just a quick look at the data across all the WHO member states. As I mentioned previously, 13.6 billion doses of vaccines have been administered globally since the start. 32% of the total population has a booster dose across WHO member states, and you can see Afro has the lowest coverage of all of the regions. So uptake has declined substantially since 2021. I know you're all feeling this. 120 million doses were administered during July and December. So if you look at the second graph, if you look at the first graphic, you can see that 120 million doses at the end of last year is really, really a low amount compared to what we saw at the beginning of the rollout. You know, available doses now, looking at the region itself, available doses in the region continue to increase, but coverage has stagnated. So you can see we have doses available, but our vaccine coverage has really stayed where it is since late November of 2022. In the African region, 40% have received at least one dose of COVID vaccine, and 33% have completed the primary series. Now, looking at coverage by country, here you can see that our countries vary, with some countries still below that 10% mark and many other countries well above the 70% target. Booster coverage in the region is still low. Booster coverage is 19% among those completing the primary series in 45 countries. So important to note, not all countries are still reporting data on booster doses. Looking at our priority populations, 49% of healthcare workers completed the primary vaccination series in 23 countries, but only 23 countries have reported, so we're still lacking data on other countries. Among our older age groups, or those that are also at very high risk, 52% of primary vaccination series in 22 countries. So I wanted to just end really quickly with a message that we still need, despite the ending of our PHIC, we still want to continue to leverage our COVID-19 vaccination legacy by really sustaining those gains. And I just wanted to show you a few examples of different gains that various countries have made. And you'll have access to these slides where you can look at them in more detail, but just a couple of examples such as GIS-supported microplanning, digital supply chain information systems. We've really made great strides in social listening and infodemic management, so we really don't want to lose those gains that we've made. And leveraging those COVID-19 lessons to strengthen immunization and health systems continues to be important. And that's really why we're having this webinar today, to introduce to you some of the new reporting requirements, and hope that you'll continue to build upon those gains that you've made over the last few years. So today, over the course of the next hour, we're going to talk about some materials that you can access as available always. The WHO Africa Region Strategic Preparedness and Response Plan, which is available online and has been sent out as well. And then we are going to talk about the SAGE meeting from September and the update to the WHO roadmap for prioritizing the use of COVID-19 vaccines. And then we're also going to talk to you briefly about the RITAG meeting that happened in November of last year, and how the SAGE recommendations were reviewed and adapted for the African region. And I'll hand it back to Ajiri.
Thank you very much, Rina, for that insightful information. Colleagues, kindly drop in the Q&A chat any questions you have, any clarity you require. Drop it there, and our panelists will jump on it and answer them. We hand over to Joachim to take us take us on the updated SAGE COVID-19 vaccine roadmap. Over to you, Joachim.
Thanks very much. And so I will provide you with an update in terms of the policies. And I think the first thing to say is that actually since the last September SAGE meeting and the publication of the updated roadmap in November, there has not been a change in the policy. Nevertheless, we had a discussion at the last SAGE meeting. You can go on to the next slide. I just show you the agenda item there. So we had an update at last SAGE meeting, which was essentially an information session to reconfirm our existing policies and to look at a quick update in relation to the epidemiological situation, the burden of disease, as well as what we know in terms of updated performance on the vaccines against the currently circulating strains. So I will give you a little bit of a heads up on a little summary on some of the things and then come back to the roadmap, which probably many of you know, but just again to highlight the main features. So we can go to the next slide. We are obviously in a situation where we have co-circulation, and particularly in the area, in the parts of the world where we have clear seasonality, where we have co-circulation of SARS-CoV-2, of RSV, and also of influenza. What you see here is essentially the evolution of the variants over time. And obviously, I'm not going into the detail, but if you go to the far right, you see actually that the most prevalent variant today is JN.1, which actually emerged fairly late and then expanded really quite dramatically. And now more than 90% of the isolates are actually JN.1, which is a descendant from BA.2.86 and is also essentially an Omicron variant and is classified as a variant of interest. There's no indication that this variant has increased virulence, but what this slide here clearly shows is that the field and the evolution of the virus remains very, very dynamic. Let's go to the next slide. So this is just a snapshot in terms of data on the reported cases and global deaths. And this is obviously something we need to look at with great caution because we obviously have much less reporting. So it's very difficult to really make a lot of sense out of this. You also see that, for instance, the African region, basically, we have no reporting. And what you clearly see is that we have probably a downward trend in relation to deaths, which is, so to say, the hardest endpoint that we have. We have also reported 80,000 hospitalization, which isn't on the slide. It is, again, it's very difficult to make really an interpretation out of this, given the fact that we have dramatically decreasing reporting, but we definitively do not have any increase in the burden and in severe cases and deaths at that point in time. Not shown here on the slide is the age stratification of cases and deaths, but we have looked at this previously, and we obviously know that the vast majority of deaths are actually reported from older adults, which is quantitatively certainly the most important risk population. Next slide. And this is why I'm showing you this, but I don't need to go into detail because I think Rina has touched on this, but this is the primary series and also booster coverage focusing on older adults, which I think is really the most important group really to talk about. And you see, obviously, as we have seen, the mixed picture in the African region in particular in relation to booster vaccination coverage. This is, of course, still the cumulative reporting where we are going to move away from in the future and as we'll discuss during the webinar. Okay, let's move on. We also looked at the performance of vaccines, and then I'm not going here into detail, but basically we looked at these questions as they are listed here in terms of the performance of the vaccines against the currently circulating XBB or a variant. We have very little data in relation to the JN1. And the data, as always, are extremely biased towards high-income countries. And basically, they are generated from mRNA vaccines, mostly the bivalent boosters, if you look at the, so to say, ancestral vaccines. And again, what we see is despite antigen mismatch, which is very significant, we see still good protection against XBB severe and symptomatic disease. When you look into more specifically into XBB subvariants, we don't really see big differences. There is some very modest data so far in relation to the JN.1 subvariant. And again, we see no significant difference in protection, but this is very limited and preliminary data. I'm not going through the other things really in great detail, but what we continue to see is the usual pattern. We see waning over time, and we do not have, for instance, head-to-head comparison data that compare monovalent XBB vaccines against ancestral vaccines, even also the bivalent booster vaccines, that allow us really to do a strict comparative assessment. But there is indication that the monovalent vaccines have some modest advantage over the ancestral vaccines in relation to protection. And this is obviously also mirrored by immunological data, which I'm not going to show here. So let's go into the recommendations. So let's go to the next slide. So this is the roadmap as it was updated in November. And basically, the features of this roadmap are shown here. So we have simplified schedules, and I come to this in a minute. We have also a simplified schedules in relation to revaccination. We have simplified schedules also in relation to primary immunization, and we are actually changing the terminology here, which I'll show you in a minute. And we stick to the high priority use groups as we had before, with a few qualifications. So older adults, adults with certain comorbidities or severe obesity, individuals with immunocompromising conditions, pregnant women, as well as health workers. So let's go to the next slide. That provides us with rationale for the simplified initial vaccine series as well as the revaccination interval. So what you see is, first of all, that we have kind of changed the terminology. So we are talking about initial vaccination and revaccination because we are obviously in a situation where essentially everybody had some level of exposure. And if there is changes in vaccine composition, we may rather speak of revaccination than of booster vaccination. So the initial vaccination is essentially now recommended to be a single dose. The only exceptions that we have is in relation to the inactivated vaccines, as well as if there is a reason to vaccinate young children or immunocompromised. Otherwise, a single dose is essentially an initial vaccination. And then in relation to revaccination, previously called boosters, we are moving towards a simplified revaccination schedules, essentially for a relatively limited group for 12 months revaccination. Obviously, all this needs to be monitored. Only exception are very vulnerable populations. And for many population groups, as you would see in a minute, we do not have, for the time being, a revaccination recommendation. With next slide. This is, I have two slides, the interim recommendation. It says final draft. I should have removed it. It is actually not the final draft, it's the final version. So we obviously have the high priority use groups, which is composed of the oldest adults, older adults with multiple comorbidities, and older adults. And we have a vaccination recommendation for an initial vaccination of a single dose. And we have a revaccination recommendation for older adults of 12 months. And then for the oldest adults or people with significant comorbidities, 6 to 12 months, even though there is a lot of, in the end of the day, to some extent, patient-provider discussion that is needed. We have the medium priority use group, which is essentially adults, as well as children with severe obesity or comorbidities, where we have a recommendation of a single dose and we have no revaccination recommendation. Next slide gives us then the low priority use group, which are essentially healthy children and adolescents, where we have no vaccination recommendation. We are not kind of discouraging this. This is why we have some text in relation to countries that are doing it, but we do not really have a recommendation to vaccinate this group. And that obviously also applies to the revaccination. Then we have subpopulations with specific considerations. These are people with moderate or severe immunocompromising conditions where more frequent vaccination is needed, both in relation to the initial vaccination as well as the revaccination. We still keep a recommendation for pregnant women, a single dose in each pregnancy. And we keep also the recommendation in relation to health workers with direct patient contact, with a single dose and also a revaccination recommendation. And then you see there's a lot of fine print. I'm not going through, and you can look at this in more detail in the document itself. Let's go on to the next, I think, last two slides. So in relation to vaccine composition, WHO has this advisory group, which is called TAC-COVAC, and there's also a group, TAC stands for Technical Advisory Group. There's also another group which looks at the vaccine, virus evolution, that monitors and that advises on an eventual change in the composition of the vaccine. The TAC-COVAC is supposed to meet at least every 6 months to review the situation. There's a meeting coming up in April. The fact that the group meets doesn't mean that they're changing the composition. And basically, you see here the recommendation that is from last year in relation to maintaining the recommendation for the XBB monovalent adapted vaccine. Noting, obviously, that access to these monovalent vaccines is somewhat limited, and we can discuss this on the sideline. Next slide, I think, is my last slide, which summarizes the discussions that we had at the SAGE meeting in March. Clearly, we have a declining trend in terms of number of cases, hospitalization, and deaths. Noting, however, the really significantly declined reporting. We note the inequity in access to COVID vaccine, in particular in relation to updated vaccine formulations, but we also note the declined demand in low and middle income countries, and maybe these things are somewhat interrelated. We have noted that revaccination with Omicron-adapted bivalent vaccines, which are the mRNA vaccine, continue to protect against symptomatic disease and severe disease. And there is an indication that the monovalent XBB vaccine have a moderate additional benefit. SAGE reiterated that monovalent vaccines should be used when available. If not available, there should not be a delay in administration, and the ancestral or the bivalent vaccines can still be used, and they have a documented benefit. And we have a reconfirmation of the priority use groups as discussed in November and as published in the roadmap. Thanks very much. I think that completes my presentation.
Thank you so much, Joachim, for this presentation. Colleagues, I crave your indulgence to have Joachim just stand in to take 1 or 2 questions because he has to jump into another important assignment. So if you don't mind, if you have any questions by show of hands, let's see. Otherwise, we release him to leave us, and he most likely will be able to jump in on any questions that must have been dropped in the chat in the course of the presentation. So over to colleagues, if there is any question by show of hands. Okay, thank you so much. We have.
Thank you.
If I may interrupt, there is a question from the panelists in the panelist chat. It's Professor Rees speaking. If you want to pick that one up, there's a question in the chat.
Thank you, Professor Rees. Yes, I think it's the person who is whose hands is up, Abdu Adamu. Please, can you come in? The floor is yours.
All right. Thank you so much, Ajiri, and thanks, Joachim, for the presentation. I think I posted my comments on the chat, but I would let me just read it out again. Joachim, so thanks for the presentation. I noticed that among the high-risk groups that you mentioned does not include incarcerated people, but experiences from diseases like tuberculosis show high transmission among this population group. Is there a reason why? And if there isn't, what informed that consideration? Thank you so much.
Yeah, so we have, I mean, one could possibly, thanks for this, one could possibly list a number of other populations that are at particularly high risk of respiratory diseases. Also, in emergency situations, that is correct. We have listed those groups in accordance to essentially the risk of severe disease. And this is where we have not seen a particular reason to highlight incarcerated people. If obviously you would be dealing with people who have conditions who are old, then obviously they would to some extent apply in accordance to our roadmap. But we have not otherwise highlighted specific vulnerable population group as such that may be particularly prone to high risk of exposure. That is correct, and I think that's something that would need to be addressed on an implementation side. That's a fair point.
Thank you very much.
Very much. We have another question from Sifo Blamini. He dropped it in the chat. If you could come online and ask your questions. Otherwise, I'll just read it. Is there any discussion or strategies to address vaccines inequality, especially for African region?
I think it has been extensively discussed, and we acknowledge, and you've seen also my last slide, that we acknowledge the inequality. I think it comes on different levels, right? I mean, we obviously have the issue of the access to the vaccine. We had the situation in the pandemic, but we also have it today that the access, at least for some countries, in relation to the monovalent vaccine is limited. There may be more discussions on this during this webinar. That's clearly one thing. The other thing is obviously that we also have much less data also on terms of performance, in terms of burden of disease and so forth. So we have very little data from the African continent, which then ultimately also translates in one way or another into equality. So I think it is on several grounds, it's on several levels. There has been also an extensive discussion in terms of the obstacles that are there from the regulatory side, from the fact that regulatory submissions for licensure are not submitted to a number of countries, and particularly middle-income countries. On the other hand side, we have the limited demand, right? So I think it is a dynamic situation, and I would not be able to speak to, so to say, where are, so to say, the rate limiting elements, but the inequality, and in particular, I would say the fact that we have also so little data from the African region is a major problem. I totally agree with this.
Okay, thank you. More questions are coming, but they're coming in the chat. Okay.
There's a question as well from Abdu Adamu in the panelist chat that I think we skipped over.
Yeah, Prof, that question, I think he asked
I see here a question, how many boosters could one have or revaccination could one have in total? I think it depends. There is no, I don't think we have an upper limit, right? I mean, it is essentially in accordance to the roadmap. And if you are in a priority group that should get revaccination yearly, you will have it yearly, or some people more frequently. We have this, I mean, this is more anecdotal, but we have in Germany a person for whatever reason got more than 200 mRNA boosters, and he seems to be okay. So I think from that perspective, there's no particular reason. So there's no safety issue whatsoever. It is on a needs basis in accordance to the policy recommendations as we just discussed it.
Thank you very much. One more question before we let you go. Would one be too simplistic in surmising that COVID-19 risk pattern is similar to flu?
I think this is that's really a complex question. I think there's a lot of similarity, but we have to be careful because the SARS-CoV-2 has not really settled into a clear seasonal pattern, and we obviously, as I've shown on one of my first slides, we remain in an extremely dynamic situation in relation to virus evolution. It looks like, it's a lot of similarity to influenza. On the program side, tapping on influenza experiences, and I know obviously that the African region has very little experience in relation to seasonal influenza vaccination, is probably something which is making sense also in relation to the priority groups. There's a lot of similarity, but I think basically saying it's the same could be a fallacy. So I think it's something that really needs to be monitored.
Okay, thank you so much. At this point, I think we'll release you to leave while we move on with our sessions. So the next session will be the RITAG recommendation from our RITAG chair, Professor Helen Rees.
Thank you very much. And if the slides could be brought up, thank you. So just for anyone who's not familiar with how these discussions go about recommendations from the global to the regional to the national, there are these 3 tiers of advisory groups. Obviously, SAGE, you just heard from Joachim, is the Global Advisory Committee, which advises the DG of WHO and member states as well on strategies around vaccination. Those strategies are then looked at by the 6 RITAGs, one for each WHO region. They advise the regional director on not only the recommendations from SAGE, but they look at the SAGE recommendations and they adapt them if any adaptation is required for their specific region. In this case, I'm going to present for the African region. And then many of you would be part of or very familiar with the NITAGs, which is the Country Advisory Committee that advises the Ministries of Health and the Ministers of Health on country-specific adaptations of recommendations that take into account local conditions. At the RITAG meeting in November, we also are inviting chairs of the NITAGs and EPI managers to join the RITAG. I've seen at least one colleague from the RITAG, Sipa Glamini, who's on this call today, but we have the RITAG members are drawn from across the region with a variety of expertise, and we complement that by dialogue with country perspectives, both, as I say, from the NITAGs and from the EPI perspective. We also have other partners there who are very involved in the immunization programs. For example, groups like UNICEF or MSF, and obviously WHO is the host of this meeting. First slide, please. So at the meeting that occurred in November, the RITAG considered the SAGE recommendations and came up with this modification of recommendations. And I'll read them out to you, then I'll explain where you can see there's a slight diversion from the main, or expansion perhaps is a better word, from the main SAGE recommendations. So first of all, the RITAG looked at the simplified single-dose regime for primary immunization for most of the COVID-19 vaccines and endorsed the SAGE recommendation. A single dose obviously improves acceptance and uptake. It's much easier than giving 2 doses as a primary series. And the data shows us that it provides adequate protection at a time when most people have had at least 1 vaccine dose or prior infection. So the RITAG endorsed the single-dose primary immunization series. We looked at the use of the monovalent XBB vaccines, and similarly to what Joachim just said, we said, when these are not available, any available EUL or pre-qualified bivalent variant-containing monovalent index virus vaccine may be used, as these provide benefits against severe disease in high-risk groups. And I'll come back to that in the next slide. But I want to just reinforce what Joachim said, is that the demand is low, and for many countries, there have not been applications to the regulatory authority for the newer generation of vaccines. So many countries would still be having the monovalent index virus vaccines or the ancestral vaccines. We then looked at the prioritization of high-risk groups that SAGE had made, and that's just been outlined to you in the tables. And the recommendation here is, and obviously this is going to look at your own particular setting. So the recommendation is to focus on protecting the most vulnerable populations by aligning vaccination strategies with the latest guidelines. So for example, in some settings in the African region, HIV might be the biggest consideration for immunocompromised people, which would differ from other regions such as Euro. So you might well at a country level then look at the roadmap and then say, we will pick out and prioritize this group or that group because we think that this would be a priority group. We had long discussions about prioritizing COVID-19 vaccination amongst other public health priorities and challenges. I obviously don't need to tell this audience that many countries in our region are really struggling with other outbreaks. Measles, very high up there. We've had diphtheria, we have cholera, we have yellow fever, and many countries don't only have one of these other outbreaks, but multiple other outbreaks to contend with. That means that the limited number of staff and available resources are being stretched very far already. In addition, as you saw, we've seen the mortality fall worldwide, but very low reporting from the African region. We also had feedback from discussions with health ministers who are really looking hard at what is the problem that they have now with COVID-19 in country, and how should they be responding in the face of competing priorities. And so this recommendation was made by the RITAG, and this is one that is RITAG specific and not from SAGE. So we recommended that countries should assess their priorities both in overall health spending, including immunization spending, and consider whether COVID-19 vaccination should be continued based on competing country needs. So rather than making a regional rule, what we've said to countries is look at your own situation. So in some countries, there will be support from groups like Gavi for immunization services and purchase of vaccines. Other countries will be middle income and won't have that. So each country environment is going to differ. So essentially, we're saying, look at your own epidemiology, look at competing priorities, and then decide whether you want to go on offering boosters. And if you do want to continue to offer boosters, consider the roadmap and prioritize based on local needs. Another question that came up in the RITAG was some confusion over what it means after the public health emergency of international concern had been lifted. as you all know, when there is a fake, that allows the WHO to give an emergency use listing for a vaccine. And there was some confusion from some countries saying that it wasn't clear either to them or from importation about what it means now that the fake has gone. Can they still use these vaccines if they haven't been approved locally and in their settings? And so there is guidance. And if you look in the chat, there's a reference for everyone to look at about the guidance for national regulatory authorities and for the immunization programs about the ongoing use of these vaccines when you have this sort of change in licensing criteria. And I'd encourage those of you who want to clarify that to have a look at this. But essentially, the countries are encouraged to continue to use these vaccines. But obviously, for those who have, most countries have a regulatory authority, it would be very important for those regulatory authorities to now also look at the vaccines that are being used in country and consider approval. The next slide. So this is the last slide, and some of the considerations for our region have already been very clearly shown. We know that population immunity has increased significantly, both due to vaccine use, but also because of natural infection. And many people now have hybrid immunity as a combination of both, which seems to be marginally more superior in terms of duration of protection than, say, vaccine or infection immunity alone. The RITAG recognized that the risk of COVID-19 is still present and that the SARS-CoV-2 virus continues to circulate and mutate. And I think this is very important, even though we might not be seeing the same levels of deaths and mortality in hospitals and the same overwhelming of hospitals that occurred earlier in the pandemic, this is absolutely a watching brief, because this could continue to change. As we said, there have been significant reductions in rates of hospitalizations and deaths. And although the African region is not reporting as actively, the anecdotal description is that the same applies here. Certain subgroups continue to be at greater risk, and those are in the table and the roadmap. And that still accounts for much of the COVID-19 related mortality. And the very elderly really do feature quite high here. And finally, what we've already said, that the available data suggests that the monovalent Omicron XBB vaccines provide modestly enhanced protection compared to bivalent variant-containing vaccines and monovalent index virus vaccines. And countries are encouraged to try and access the most up-to-date available formulations. But in the absence of those being available, all these vaccines will give protection, particularly against severe disease and hospitalization. So those vaccines are still encouraged to be used. So I'll stop there. There was also a question in the chat, which I think was for Rina, which was, well, what sort of vaccines are available in the region? And perhaps that's something that we should touch on, but I'm very happy to take any questions. Thank you.
Thank you, Prof. Rees, for that insightful presentation. Now we have a clue as to where we stand regarding COVID-19 vaccination within the region. To take us further on the monitoring framework for the region, Donald will take us on the revised global COVID-19 vaccination monitoring framework. Donald, over to you.
Great, thank you, Ajiri. Good morning, bonjour, bon dia to all of the participants. My name is Donald Brooks, and I'm the lead for COVID-19 vaccination data and monitoring, sitting at WHO headquarters. And as Ajiri has mentioned, following the policy presentations from colleagues Joachim and Helen, we'll now transition into a discussion on what this means for the data that are being collected at country level, at regional level, and at global levels, as we continue to try to understand both the rollout of these vaccines and their impact on the evolving pandemic. I won't spend too much time on this first part. And again, as Rita mentioned earlier, you'll get these slides after the fact. But clearly, since the beginning of the COVID-19 vaccine rollout, the pandemic has changed and the vaccine rollout itself has changed. And this has necessarily required changes to both the policy recommendations, as we just saw, and how we're monitoring the programmatic implementation of COVID vaccines. In particular, and we'll get into this in the next few slides. I won't, the first bullet is already clear. We're shifting recommendations as to how COVID vaccines will be used. Second is using the current indicators, data are moving very slowly and in very small increments. And this is due to a number of reasons, as highlighted previously, notably quite high uptake of COVID-19 vaccines and an equaling of demand for COVID vaccines with available supply. As well, the public health emergency of international concern, the FAIC, at the global level has been declared over as of the 5th of May last year, and many member states have already made this change, ending their equivalent states of emergencies over the past few years, and many continue to do so now. So recognizing the need for this change in monitoring practices, even before the most recent policy recommendations at the global level, WHO and partners organized a global convening in March of last year to discuss how, taking into consideration how the vaccine rollout and the pandemic are evolving, how we need to think about monitoring the use of these vaccines moving forward. Coming from this convening, a number of recommendations were made. One was to revise the global level framework for the 2024-2025 period. And this was brought forward through an interagency working group that was established in May of 2023, bringing together global and regional level, as well as a few representatives from the country level, to discuss across all aspects of vaccination for COVID-19, what are the key indicators that are required at global level to inform decision-making and programmatic support. Before I get into the changes to the monitoring framework itself, I want to highlight that this implicates both the content of the data being collected and recommended to be used, but also the frequency of its collection. And that's what's displayed on this slide here. Obviously, we've gone through a number of phases in the COVID-19 pandemic so far, requiring up-to-date data at all levels of the health system, all the way from health centers, district levels, national levels on the countryside, but also at the regional and global levels as well. And so this graphic shows how we're transitioning from the weekly level, weekly frequency data that we've had for most of the introduction of these vaccines down to what we're thinking will be the new normal for COVID-19 vaccines based on the current epidemiologic situation and the products that are available. So we shifted at the global level from weekly to monthly reporting at the end of April. All of the African region countries have been requested to continue reporting weekly based on the needs for these data at the regional office. And so Ajiri, my colleague, will speak in the next presentation about African region specific recommendations, and I'll go through what we're doing at global level. Lots of overlap, but just to make that distinction clear. We've shifted as of the end of September of last year from monthly data collection to quarterly, and will remain at quarterly data collection through the end of September this year. So a year of quarterly collection, at which point all COVID-19 vaccination monitoring will shift into the annual reporting cycle, as WHO and UNICEF have been doing for the past many years through the electronic joint reporting form for routine immunization. You'll see here points 2 and 3 that already there are some data that are no longer needed more frequently than annually. And so these data will already be shifted to annual collection as of this year. So collected in the electronic joint reporting form for 2023 data that has been launched as of the beginning of March. So there are 2 places where data will be collected for this year, but generally transitioning towards a single collection of COVID-19 related vaccination data in the annual process, with other vaccination data collection that is happening and has been happening. From the content side, obviously, many data points have been requested over the course of the vaccine introduction, and we recognize the considerable burden that this places on not only country colleagues, but regional colleagues all along this pathway of data from health centers to global level. And so in an effort recognizing this burden, but also the declining need for many of the data points that were important at other stages of the vaccine rollout, we've streamlined this monitoring framework considerably. You can see here in the those that are not shaded in blue, those that are in white, these are the remaining data points that we continue to require at levels regional and global on a more frequent than annual basis. So these are data relating to the products in use and how they're being scheduled in each country, policies for the use of vaccines. This is increasingly important as we see many of the policy changes, as Joachim and Helen presented earlier, enter into effect in countries. Uptake continues to remain a very important measure for tracking the continued implementation of COVID-19 vaccines, in particular in risk groups, safety data, and data on integration. And so I'll come back to the uptake indicator in a moment on my next slide. But just to mention, for both the policy and uptake indicators, obviously the roadmap, even if it is considerably simplified from previous versions, it remains very difficult to implement from a monitoring perspective for many countries, especially those using paper-based systems. And so in the monitoring language, we've tried to simplify these even further so that they're more aligned with existing terminology for other adult targeted immunizations, in particular influenza, for those countries that have experience with influenza vaccines, but generally definitions of target populations that are more familiar from a monitoring perspective. Those that are in blue here, I won't spend too much time, are those questions in the updated framework that are only required annually. And so these, as I mentioned just a moment ago, are already included in the annual electronic joint reporting form, which was launched in March. The data that are collected on COVID there are those on procurement and pricing, stock and wastage, and then a single once-off question on immunization information systems and how COVID vaccination continues to be monitored. Coming to the question of uptake, we saw in the updated policy recommendations the simplified single dose recommendation for primary vaccination for COVID, given high vaccine-induced and infection-induced immunity, as well as the recommendation for periodic revaccination of high-risk groups. And we already saw this come through in a question, how many booster doses should people be getting? If we are on booster dose 4, 5, 6, obviously this becomes increasingly difficult from a monitoring perspective to collect and bring to all levels of the health system. With this in mind, and given as well that now it is less a question of how many doses have I received, and more a question of when was the last dose I received, we're now shifting from the current indicators we've been using for monitoring uptake, which is this number of people have received a complete primary series, this number of people who have received a booster dose. Since the beginning of the rollout, we're moving away from this dose-based cumulative since the beginning of the rollout indicator towards a single simplified annual uptake indicator that is the number of individuals or the percent of population that has received one dose during the calendar year. This one dose could be a primary series dose, the first dose. It could be a first booster dose. It could be a sixth booster dose or a fifth booster dose. It really depends on where the person is in their own healthcare journey. But all of them will be counted as a single dose administered in the specific time frame. So this will considerably simplify reporting of uptake. We will continue to recommend and request data on uptake disaggregated by risk groups, and I'll get to this in my next slide. So that has not changed. It's really the indicator itself that has changed. And so this indicator now looks very similar to how flu vaccination is monitored in countries who have introduced influenza vaccines. These slides are available and will be available after this call. All WHO member states have received a memo as well from the WHO African Regional Office alerting them as to the shift in this monitoring framework and the request or the changes to requested data. So these are also available via memo to ministries of health. But just quickly, as I mentioned, products in use, so really looking to understand which products are being used and actively administered in countries, keenly looking at those that are using variant-adapted vaccines. This is an important piece of information for use at all levels to understand how new products are being introduced and used. Scheduling, as I mentioned, trying to understand which groups are still recommended in your countries to receive COVID vaccines, simplified slightly from the terminology used in the roadmap, but aligning largely, as well as those now recommended to receive a periodic revaccination. If we look at uptake, as I mentioned, still looking to understand uptake in specific risk groups, notably older adults, health and care workers, adults living with chronic conditions, pregnant women, and uptake disaggregated by gender, as well as any other groups for which you have data and you would be interested in sharing with WHO. Some countries, this is travelers, in particular those who are doing Hajj journeys, in that these data are normally available for them. And as I mentioned, safety continues to be requested information on AEFIs, as well as a question on integration and looking at how COVID vaccines are being delivered with other health interventions. Just wrapping up for me in these next two slides, what this will look like in terms of the actual reporting process, and my colleague Ajiri will also re-emphasize this for the Afro context. But we will continue, and we have shifted to quarterly reporting, as mentioned. Q1 data, we have only recently just ended Q1 as of a few days ago. So we are getting ready to start the collection period for Q1 data. And this will be similar to how data have been collected for many regions throughout the vaccine introduction, with a 2-week delay before the data collection starts. So Q1 data, January through March, will be collected from the 15th of April through the 14th of May, 2024. So giving a month for that data reporting to happen, with a 2-week delay for consolidation at the national level. And this will be done through the electronic joint reporting form COVID-19 module. And so this, many countries in Afro may remember this module from early in the rollout before it was discontinued for Afro. It will again be used in the African region moving forward to consolidate across the different regions of WHO, and also to simplify data management, access, and analysis. Again, my colleague Ajiri will speak more to this in a moment. But you'll see that this same cadence will continue through the end of Q3 2024. So Q2, April through June, will be reported July 15th through the 14th of August. And then quickly, and just a thank you from all of us at all levels. Again, reporting data is burdensome, and we can and are still working on improving how we loop back with you, how we're using the data that are shared from countries to region and global level. But just to say that it is used every day and has been for the past 3 years during this vaccine rollout, whether that be for policy discussions, as Joachim and Helen discussed, from the from the policy technical advisory group angle, from COVAX-related discussions on deal making and making sure that supply is available. So really used at all levels. And we are in this optic trying to make sure that these data are also coming back to you. We have revised the global level COVID-19 vaccination, global level COVID-19 dashboard. And this was launched at the end of 2023. It still remains available at the same link, but is now in the WHO data environment, which is easier to use. Additional vaccination data, all of the data that I just mentioned will be added there, will be accessible for your download and use and comparison. We have a monthly, now quarterly report analyzing COVID-19 vaccination data at the global level. This link will be available in the slides when they are shared out. Please do sign up and you'll receive this direct to your inbox. And then finally, for me, just to say, many of you may be familiar with the technical guidance that was shared early in the vaccine introduction on considerations for the collection and use of vaccination data. We are updating this technical guidance to take into consideration boosters, the changes to the indicators we just discussed, the changes to policies. This is underway and will be made available on the WHO website and shared through existing channels with member states through AFRO and other partners. And with that, thank you. Back to you, Ajiri.
Thank you so much. Thank you so much, Donald, for the global insights. Now we come to the our own region, what we have to do going forward. Let me share my screen. Okay, so having had the global framework, what is the implication to us at the Afro region? At the Afro level, we had developed a platform for collecting this data. And that meant that we had to stem down the use of the EJRF model. So going forward with this transition, we will discontinue using the data systems platform that was developed at AFRO, and reporting of the vaccination data will now shift to this EJRF platform. Of course, we know that the EJRF platform is the same tool that is used on a yearly and routine basis for general vaccination reporting. Now, each country is supposed or is expected to appoint a designated focal person who will be responsible for completing and submitting the country's EJRF COVID-19 form. For purposes of those who have maybe forgotten, we will have a session where we will have a quick overview on this EJRF model. Laura will take that session, just some 10-15 minutes to just walk through and get intimated once again for those who are out of touch. Now, like Donald said, the reporting of vaccination data had always been reported on a weekly basis up until now. Going forward, it will also be reported on a quarterly basis using the EJRF platform. Reporting of the revised minimum data sets will be on a quarterly basis through at least Q3 2024. Donald had already given a breakdown of all of this data. The diagram here just shows the transfer from our own platform to the EJRF platform. Now, Following Q3, all requested COVID-19 vaccination data will be merged into the 2025 annual WHO-UNICEF joint reporting form. Again, that has been touched on by Donald, just re-emphasizing this. Modification of data collection tool is required to support the new reporting, especially considering that we now have a simplified single dose indicator, uptake indicator. We might need to make some adjustments in our tool to be able to collect all of those information. And then finally, the data system developed in the context of vertical COVID-19 should be integrated into the RI system, enhancing them when feasible. The table on the right also re-emphasizes what Donald touched on, which gives specific dates as to when this reporting will be taking place. Again, the data for product in use, scheduling, uptake, safety, and integration data will now be all quarterly basis. And Q1 2024 commences 15 April to 14th May. That collection will start off in the EGRF COVID-19 module. For Q2, April to June, between 15th July and 14th August, the EGRF module will be open for all of those collections. Q3 2024, July to September, between 15th October to 14th November, the EGRF COVID-19 module will be open for the data collection. And then for the annual reporting, we have the procurement, supply and wastage, and immunization information systems data all collected annually. And the platform will be opened from the 6th of March to 30th of April for the EGRF annual questionnaire collection. So that's the actions required from us at the AFRO level going forward. That's the update from my end. We will quickly touch on the EGRF platform, quick overview of the platform before we take questions. Over to you, Laura.
Thank you very much, Ajiri, and I'm expecting that people can now see my screen. Let me know otherwise. I'm here on the EGRF platform, and I hope that this is a very familiar platform for most of you. After doing a quick assessment of people asked to report COVID-19 data, we realized that very few were not already registered into the EGRF, and that you should be very familiar with what I'm showing you. However, if it's not the case, please feel free to contact us at egrf@who.int, and we will make sure to grant access to anyone that needs it. I've put the URL, the link to the URL in the chat, so you can already check your access rights. And just want to mention that the URL I put on the chat is not the same that the one that you are seeing on the screen, because I'm here, as it is mentioned on this banner, I'm here on the training site. The URL you have on the chat is to the official site. Here it's really a site that was created for training purposes, and so that I can fill in dummy data. I'm here impersonating Dr. Landry Coakley, who is the EPI manager from Benin. So you have here really the picture of what you see when reaching out to the EGRF from a country perspective. You can see that in this homepage, you have different form types, the GRF ones and the COVID-19 ones. So you would find the annual data collection questionnaires here under the GRF form type, whereas you will find the COVID-19 one under the COVID-19 form type. And as Ajiri and Donald mentioned, most of you would have to report in both places. In order to report data, the only thing that you need to do is to click on the tile where you want to click to report data on. Let's suppose you want to report procurement and pricing data for COVID-19 into the annual data collection. You will click on GRF 2023. 2023 stands for the year for which the data is collected, not the year we are collecting the data. So this year we are collecting 2023 data, and we are asking you to report procurement and pricing data for COVID-19 for 2023. So you click on the GRF tile, and then you will see your country name here. You have to hover over it, click on the view icon here, and then you land in the form properties, where you can see all the topics that you have to report data on. And I'm sorry, I've checked out all the topics, so I'm gonna let this go very quickly, but just wanted to say that the only pain point in the EGRF on how to report data is really that while many people can report data on the EGRF simultaneously, only one person at a time can report data on a specific topic. So if I want to report procurement and pricing data, I will have to check out the topic, take it a bit like you are checking out a book from a shelf so that only you can read it. And it's the mandatory step, so that then you can click the edit button, enter into the form, view where the procurement and pricing topic here is, and you can start adding data here, and especially the COVID-19 one. And most of you know how to do all these steps. The EGRF is very user-friendly and intuitive. So, but if some of you need some orientation and need a little bit of training to be given into the tool, then feel free to contact us. But if you don't want to waste your time by contacting us, you also have within the platform some tutorials and useful information. You can see here that you have tips for this page, and if you don't know how to add a row here, you can click here and you will get, by clicking next, a little video that explains and shows you how to do. So the tool is filled with plenty of tutorials and support, so that you can get answers to any of your questions. Feel free also to click on this lemon. This is the digital adoption platform we've added, which is Lemon Learning, where you have access to guides, to user guides, and so on and so forth. You can select the language here. The platform is available in French, Spanish, Russian, and English, obviously. And you can navigate from a form type to another. I'm going to navigate now to the COVID-19 one. I'm just mentioning that this is for the purpose of the demo. This is a dummy questionnaire. This is absolutely not the one you're going to see on the 15th of April, but you will have to do exactly the same thing, which is to check out some topics that you want to fill in the data for, click the edit button, access the questionnaire, fill in with your answers the questionnaire, and then once you're closed, you're done filling in the data. The only thing that you have to do is to check back in all the topics, bringing back your book into the shelves, and hit the submit button. So this is a very easy and user-friendly platform where you can report your data. And again, you are not alone. If you have questions on how to use it, use all these tooltips and other support that you have, or contact us at egrf@who.int. I tried to be quick to meet the deadline of the webinar, but I'm happy to answer any question if needed.
Thank you very much, Laura. That was quite helpful, and that was smart and quick of you to have considered the timing. So, colleagues, participants, and everyone, now is the time to seek clarity. Any question you have regarding anything that has been talked about in the course of this webinar, now is the time to let us know your thoughts by show of hands. And we can invite you to the floor, or we will invite you to the floor to ask your questions. Okay, while we wait, Professor Helling, we have a question for you on the question and answer tab. Is there any initiative from the RITAG to strengthening high-level political commitment in the Afro region? This seems to be the missing piece of COVID-19 integration into the PHC. This commitment was key during the rollout stage of the vaccine. Professor Rees, is she still around? Okay. I think she stepped out. Yeah, okay. And then this question, I think this will be for Donald. Is there any guidance from the global level to support countries for COVID-19 vaccination data collection at the facility level in routine mode? Is the COVID-19 tracker still relevant for COVID-19 vaccination data management and use? That's a question for you, Donald. Over to you.
Great. Thank you for the question. A really good one. So there are some guidelines available generally for from WHO and UNICEF on the integration of COVID-19 vaccination into routine immunization, routine health services, public primary health care, whatever is appropriate in your context. I did mention too that we are, yes, updating the original considerations for the monitoring and use of COVID-19 vaccines more from the what we recommend be monitored. This touches on the systems to a certain extent, but not exactly your question. I think it's an interesting one, but it really depends on country context and what your capacities, your foundations, the available financial and human resources that you have as to deciding what makes most sense. We see a number of countries globally that have put in place systems like the tracker that have been able to mobilize domestic resources for maintaining these systems after COVID, no longer relying on COVID-specific financing. Countries like India, England, and a handful of others, Nigeria too, with their EMID system, are looking to build on these systems, add in routine antigens to them, to digitize and move towards digital systems with individual level information for their routine programs. This, we know, is not appropriate in all cases, whether that be because it's not possible to commit domestic resources, there aren't enough tablets, there aren't enough trained individuals, in that we saw quite a few countries move towards a tracker-like situation and then have difficulty implementing them because of the requirements of these systems. In these countries that did have these difficulties, it may make sense to stand these systems down and integrate uptake of COVID monitoring of COVID uptake into the regular DHIS2 or other similar system basis like there is for routine immunization. This depends to a large extent on how you're continuing to administer COVID vaccines as well. We were, personally, I was in Ghana about a month ago, and in some vaccination sites, COVID vaccines are being given right next to where childhood immunizations are given. It may make sense in that case to completely align reporting. Some cases that COVID vaccines may be given only in other specific areas where routine immunization is not happening. So there, a separate but related system may be needed. So a long answer to, there are some guidance documents, and my colleague Alba has just put the link in the chat for the general integration guidance. We will have an updated guidance that will come out soon on the considerations and use of monitoring COVID vaccines. And then it really is on a country-specific level. And if your country has particular questions, I can't see who asked the question in particular, do reach out to your country office, regional level colleagues, and then we can provide support on a one-to-one basis if needed. Back to you, Jerry.
Okay, thank you so much for that. I hope that brings clarity. And then we have one more question from, I think it's in French. That will be for Laura. It says, regarding the recording of COVID-19 data in the EGRF on the current platform, that there is no access to enter data for 2023 nor 2024. There is only for 2021 and 2022. Over to you, Laura. Question.
I just unmute. Okay, I'm going to respond in English, although I was tempted to do it in French. Yeah.
No, we have a translator, so it's fine.
Bien, alors je navigue vers le français pour répondre en français à la question qui m'a été posée dans cette langue. Effectivement, si vous allez sur le portail, pour l'instant, vous ne voyez que les questionnaires de 2021 et 2022 avant qu'on shift au système Afro. Et puis, le prochain questionnaire dans lequel on va vous poser des questions pour les données 2024 uniquement, c'est-à-dire de janvier à mars 2024, va être disponible sur la plateforme le 15 avril, comme indiqué par Donald et par Adjiri. Le 15 avril, vous recevrez dans votre boîte email une notification automatique de la plateforme IGRF vous informant que le questionnaire est maintenant disponible et que vous pourrez répondre à ces questions. Donc, normalement, si vous allez maintenant sur la plateforme, vous voyez le GRF 2023 dans lequel vous pouvez informer les informations de procurement, de stock et de système d'information pour 2023. Et ensuite, vous irez le 15 avril 2024 sur la plateforme pour informer des données 2024, janvier-mars 2024, pour le nombre de doses administrées, pour des informations en matière de politique et de calendrier vaccinal, pour des informations en matière de sécurité vaccinale et d'intégration. Donc, voilà, c'est un petit peu comment ça va être organisé. Et donc, c'est tout à fait normal que pour l'instant, vous ne voyez que les questionnaires 2021 et 2022 qui sont là parce qu'ils étaient là à cette époque. On vous demande de rien faire avec eux. C'est à titre informatif uniquement. Il n'y a rien à remplir dans ces questionnaires pour le moment. J'espère que j'ai été claire et sinon, je suis heureuse de répondre à d'autres questions.
Okay. Thank you so much. I hope we are all clear. And we've touched on all of your questions. So at this junction, we would like to, if there are no more questions, we would like to bring this webinar to a close. Unfortunately, Rena had to jump into another meeting. So I will take it upon myself to bring this meeting to a close. Thank you all for your participation, your active participation. Thank you for the support. And thank you for bearing with us we've shot some 7 minutes out of the time. Thank you all. If you have any further inquiries, you should reach out to any of the panelists. Take note that these presentations will be shared at the end of the webinar. And you also remember that there will be a survey at the end. Please take out time to do this. Thank you so much for your time, and over from us.